Good morning, everybody. Our respected Dean, Dr. Mohan Joshi, esteemed faculty, senior teachers, colleagues, and friends. On behalf of the Department of Surgery and the Staff and Research Society, I welcome you all to the 25th S.R. Talwalkar Oration. I request our guest speaker, Dr. Pramod Bhende, to please light the lamp and inaugurate this auspicious occasion.
Distinguished speaker, Professor Pramod Bhende sir, Padma Shri, Dr. Lahane, my teacher, Dr. Dabholkar, Dr. Anantram, ex-dean and director of Municipal Corporation, Dr. Yevlekar, Dr. esteemed Nadkarni, Dr. Madhuri Kulkarni, ex-dean, all ex-distinguished teachers, professors, heads of the department. It was when I was a trauma registrar in 1985. I was working with Dr. Dabholkar, and in trauma registrar when I was working on duty, a professor of physiology from Nagpur, Dr. Kher, met with an accident. He had flail chest and he was brought to E ward when I was on duty. Without knowing that he was Dr. Kher and Professor and Head Department of Physiology from Nagpur Medical College, we went ahead with our standard treatment, that is insertion of ICD because he had hemothorax. And then subsequently he was treated well with standard treatment of flail chest, and then he was discharged. He was alright and he was discharged. That time the dean was also the head of the Department of Physiology, and that was Professor Dabholkar, whose name is here to this particular hall, Dr. N. Dabholkar. Dr. Dabholkar used to peep in E ward. That was his only visits in E ward as a dean, and we used to be surprised because this patient was the head of the Department of Physiology. And then at the end of discharge everything went well, and then this Sir Kher was related to Talwalkar family, and Professor Kher went to Dean's office. Dr. Nadkarni was then the head of the department. Dr. Dabholkar had gone to Goa and he had kept Dr. Nadkarni on call, SV Nadkarni on call. So the patient went to Dean and I was called to Dean's office, that urgently called by Dean. So I was a little tense and worried what has happened and why the Dean is calling. And Dean called me and he said that Professor Kher is extremely happy about the treatment which you have offered them from trauma ward. And he is donating this. This was more than 3 times the salary of a full-time teacher. And please tell your head of the department or Professor Dabholkar. So Dabholkar sir was away, so I telephoned Professor Nadkarni and he immediately came. And he said that we will start this fund as a corpus fund, from which we will start the first oration, and that was S.R. Talwalkar Oration at the request of Dr. Kher. Then the name of S.R. Talwalkar was given for this oration. The first oration was given by our own plastic surgery head, retired plastic surgery head, and I distinctly remember the topic, the wave of a surgeon. That was the first oration in 1986. Thereafter, several national and international luminaries have delivered this oration, and when recently I was in Madras, I found the work of Department of Ophthalmology, especially Vitreo-Retinal surgery was something which is out of the world. So we have deviated only twice. Once we had called a medical gastroenterologist for this oration, and this is next today we are inviting an ophthalmic surgeon in the Department of General Surgery for the oration which is to be delivered ordinarily by general surgeons. So for his exceptional contribution for the Vitreo-Retinal surgery, nationally and internationally acclaimed person. So then he acceded to our request and we are here to listen to his thoughts. That is the background of oration. Thank you.
For that very wonderful story. I would now like to invite on the dais our chairpersons for today, Dr. Prabhakar, our Head of Department of General Surgery, Dr. Ashish Vaidya, who is a senior ophthalmologist who has done his post-graduation at Sion, and his fellowship under Dr. Bhende at Sankara. Dr. Dabholkar, who has been ex-professor of surgery at Sion and ex-dean of Chhaya Hospital. Dr. Pant Vaidya, who was ex-HOD anesthesiology. Dr. Chaukhar, ex-head of Department of CBTS. Dr. Thatke, ex-head of Department of Plastic Surgery. Dr. Yeulikar, who is ex-HOD Medicine and ex-dean of LTMGH. Dr. Anantram, who was Honorary Professor of Surgery at Sion. Dr. S.P. Nadkarni, also Honorary Professor at Sion. Dr. Meena Kumar, ex-HOD of Surgery at Sion. Dr. Motwani, ex-head of Department of Ophthalmology at Sion. Dr. Lahane, ex-dean of JJ Hospital and a very eminent ophthalmologist. Dr. Mamta Manglani, ex-HOD of Pediatrics. Dr. Madhuri Kulkarni, ex-HOD and ex-dean of LTMGH. Dr. Anjali Nicholson, who was ex-HOD of Nair Hospital in Ophthalmology. Dr. Neela Patwardhan, a very eminent ophthalmologist. Dr. Saroj Sehdev, ex-HOD of Nair Hospital Ophthalmology. Dr. Vijay Kulkarni, an eminent urologist. Dr. Dastoor, an eminent ophthalmologist. Dr. Bhagwat, ex-HOD of Nair Hospital. Dr. Jahangir, an eminent ophthalmologist. Dr. Anjana Kokhani, an eminent ophthalmologist. Dr. Chahande, HOD Ophthalmology of JJ Hospital. Dr. Paritosh Kamdar, an eminent ophthalmologist. We are gathered here today to listen to the powerful words of Dr. Bhende on past, present and future of retina. In the past, we have had only limited understanding of the retina and treatment options were often restricted to identifying only the gross abnormalities. However, with the advent of OCT and fluorescent angiography, diagnosis has improved. Current treatment options include laser therapy and anti-VEGF injections. Our Department of Neonatology, under the leadership of Dr. Swati Manekar, has been running a screening program for retinopathy of prematurity for the last decade. We have a specialized team who comes from Vitreo-Retinal Hospital and does bedside indirect ophthalmoscopy to diagnose this as early as the 3rd or 4th week of life. Follow-up is then weekly or twice weekly, and treatment is by laser therapy or intravitreal injections. They have seen wonderful results and patients have followed up with their department for up to 3 years. As general surgeons, we often see polytrauma patients with severe retinal damage. Awareness about the advances in the field of Vitreo-Retinal surgery will help us to understand the potential for restoring vision for these patients. I now request Dr. Sandhya Iyer to introduce our speaker for today.
Dr. Pramod Bhende was born on 6th of September 1960 in Akot, a city in the Vidarbha region of Maharashtra. A bright student from the beginning with a keen interest in sports, he was the captain of the cricket team in school. He went to do his MBBS and MS Ophthalmology from Government Medical College, Nagpur. He then pursued a 2-year fellowship in Vitreo-Retinal surgery at Medical Research Foundation, Sankara, Nethralaya, Chennai from 1991 to 1993. He then joined as faculty at Sankara Nethralaya. His special interests in the field of are surgery for pediatric retina, including retinopathy of prematurity, diabetic retinopathy, and combined procedures involving anterior and posterior segment pathologies. He was visiting scholar in the Chinese University of Hong Kong, 1999. He rose in the rank to become director of the Department of Vitreo-Retinal Surgery due to his hard work and dedication. Keenly interested in research, he has 111 publications in national and international peer-reviewed journals, 8 book chapters, and is a reviewer for 12 journals. He is a popular speaker and has 450 presentations and 12 orations to his credit. He has achieved many accolades over the years. He received the gold medal for excellence in ophthalmology and VR surgery by the Uttarakhand Ophthalmological Society in 2012. Asia Pacific Academy of Ophthalmology Achievement Award 2016 and Medical Excellence Award 2019 by World Tamil Chamber of Commerce, Chennai in 2019. He is member of many prestigious societies such as the American Society of Retina Specialists, Retina, Asia Pacific Pediatric Retina Society to name a few, Lokmanya Tilak Medical College and General Hospital. On behalf of the Department of General Surgery is pleased to present S.R. Talwalkar Oration 2025 to Professor Dr. Pramod Bhende in recognition of his pioneering work in the field of Vitreo-Retinal surgery and invite him to deliver a talk on past, present and future of retina.
He has been an ex-dean at Sion.
Joshi for having me here, and it's with the eminent faculty and past, present dignitaries here. I'm really overwhelmed, and I really know, I would say I'm speechless. Okay. So, and I have a few teachers here, I can see, few familiar faces, my colleagues, my friends, and really overwhelmed here. So, we don't know what to talk about that. So, and thank you very much for having me here. It's a great honor for me. And let us begin. And being a retina person, probably I'm used to talking about technical aspect of the retina. And when he suggested me past, present, and future, I said yes, we'll do that, because that's a nice way of going through past history, the thing which will always interest us. But at the same time, probably I hope few things I may be out of, because other specialties sometimes maybe I may not be doing justice, so please bear with me at that. So, we'll start what we know as since the time of Shishruta and cataract couching. Ophthalmology is recognized as a surgical specialty right from the 2000 BC. The first and most important invention what we had, fundus visualization. And it's interesting because, in fact, I learned a lot of things while preparing this talk and looking at going to the old books and history books. Like first time, the fundus or optic disc was seen in a cat's eye, immersing the cat in a water so that neutralized cornea power, and that was the first thing we could see inside the eye, and living animal rather, I would say. Adolf Bushman, actually he also tried to make an attempt, and he is known for his pioneering work in actually respiratory system and not in ophthalmology. And quite a few of these eminent people, they have a versatile, large field of research, and one specialty to subspecialty which probably we lack. We all of us, most of them having a tubular vision restricted to one field rather than having they are switching from one specialty to other specialty. Van Helmholtz, who has introduced or rather invented ophthalmoscope, it was uniocular at that time, 1851, and that was a landmark invention and immediately accepted all over the world, and it actually revolutionized the practice of ophthalmology that time. And it's always compare that with the telescopic invention which has happened in 17th century, and stethoscope which was 19th. These are few landmark inventions we talk about, we change practice of medicine for all of us. So, and then subsequently ophthalmoscope, I'll come to a little bit later on that. Design and optics, when you talk about that, become part and part of endoscopic evaluation. What we do now, going to miniature surgeries, every specialty, and endoscope is an integral part of our practice now, and that is what this principle brought into. So, Oliver Gelstrand, he has a huge amount of work in optics, subsequently associated with Zeiss company, and he brought something what we called as aspheric lenses, because to reduce the reflexes to see the fundus. Basically, he is known for slit lamp examination. Probably all ophthalmology, all of us know how valuable slit lamp for us. Without that, we cannot complete examination both for anti-segment and posterior segment as well. But what is biggest contribution what he had, which reflex-free fundus examination. Basically, what we all know is now as a so-called Gelstrand principle. What it means, like in order to eliminate, basically cornea has a lot of reflexes, and small tubular aperture, when you send the light in and reflected light, you want to look at it, so it causes a lot of reflexes. And to order to eliminate this cornea and other reflexes, the light for illuminating the retina should not overlap the visual pathway, and that basically this picture what I am showing here is light is going up, and what you are seeing other 2 points are basically reflexes or image of the doctors or physician's pupil, so that they all three are not falling in, overlapping each other, and that's why that what you get is a reflex-free like a ophthalmoscope, and that's what his contribution there. And obviously this principle again now being used, basically what we all endoscope new design, so you have another fiber, it goes to illuminate, and you have reflected light is passed through other two or one post. Basically it depends on 2 dimension or 3 dimension what you are working on it, but that is what this principle, and that he had got almost 100 years back, and still we are amount of foresight and involvement these people had. Coming to evaluation further, examination, he has brought in first indirect ophthalmoscope just a year later, and one, what is known for is basically binocular indirect ophthalmoscope and also what is called as something self-illuminating indirect ophthalmoscope, and that is what revolutionized entire retinal surgery, and that's he is called as father of retinal surgery. So this instrument brought in, of course, there are other inventions he add on, we'll go to that, and we are reached now modern era. We have video indirect ophthalmoscopes, so we can directly visualize, get a screen or you can all the images with being routinely used, and basically most of the time it uses a light source to take pictures as well, but mainly for as light source. Coming to the fundus imaging, it has a sea change, and this is what it's a long and impressive and effort to clear photography of the fundus. So basically first after, as I said, 1951 by Mann, and another landmark thing came into is the first fundus camera, because the same principle was used. First fundus camera was brought up basically Zeiss company when Gulstrand was working with them, and he is one of his disciples, Nardenson, and using that reflex-free fundus ophthalmoscope, he came out with the first camera, but however that time it was just 20 field. First an 30-degree picture, and then subsequently 55-degree fundus image. It was almost 30 to 40 years it took to go down to 75 degrees, which what we call as like a montage now. And now we have in a subsequent 97, 2000, 2002 fundus images, we are having a new cameras we call as wide angle, and now even ultra wide field imaging that is gives up to 200 degree of fundus image. So in fact ophthalmic examination become much easier, and I recently was talking to somebody, and particularly where a busy OPD is there, although I won't personally justify that, but a lot of people are talking about, I get the history done, fundus photograph is done, I look at the image, fundus photograph 200 degree, almost entire fundus I can see, and just I don't touch the patient, and this is 200 degree without dilatation of the pupil. So patient need not wait in a clinic. I look at the fundus and just I'll dispose them off. So the practice has significant changes. So basically, as I said, fundus camera is basically on the principle of monocular indirect ophthalmoscope, and depending on wavelength of light you use, it becomes now either use a white color to get a fundus picture, color fundus picture, and we use something like a red-free fundus photography. Generally, a green filter is put, or you have a blue filter, like an autofluorescence we are talking about now with some variation, and definitely all this so-called multimodal imaging or changing the wavelength of light, which gives a different information when we examine the fundus, and that subsequently added up angiography. We'll come to that little bit later. So typical fundus image, what you see is 30 to 50 degrees beyond the your central like a temporal arcade, macula, disc, and few vessels. And when you montage, this is around 75 degree, it goes far beyond now, and then comes the ultra wide field or wide field, something anything between 50 to 200 degrees of field we are having it. The advantage of this, basically, as I said, you get a quick image, better enhanced resolutions now, and duplication, because of this is our digital images now, so easy to transfer your pass on to your colleagues, classification, treatment plan. When you now different study, definitely you have to define protocols. These images are extremely useful now. And what is important for me as a as a pediatric ophthalmology, and quite sometimes the babies are very, very uncooperative. Sometimes pupil doesn't dilate, particularly we're talking about ROP kids. So this gives, I'll just show you little bit, come to that what happens. So there are different brands are there available, anything between 120 degrees to almost 200 degree fundus picture we can get this, and that is what is you have Claris almost 160 degrees, Mirante same around 60-65 degree, and the last picture that said what I am trying to show is we have a early treatment diabetic retinopathy study long back, and with a regular fundus camera, with typical camera what we used to talk about 30 degree 40 degree field, and they defined something like that ETDRS 7 field, and those 7 fields were used routinely for all the diabetic retinopathy classification and then this defining protocol. And with new fundus camera, those are the 7 fields what you see, central circus, and beyond that what you see is now. So things have totally changed now. So that's the difference we have, and what we really again important now, And these are all the lesion I am showing here. What you see, capillary dropout areas, no vessels here. These are new vessels here. And all these are beyond that 7 field. So if you still restrict to that 7 field, you miss all those things. You assess adequacy of pan-retinal photocoloration diabetic eye when you do here. And previously again up to equator we used to talk about, and this is far beyond equator, and this is one of the reasons they have recurrences. And if you examine this and you get this picture, you know laser may not be adequate enough, we need to add additional treatment. So decision making also it is helping us now. And this is what I wanted to talk about. Small pupil, babies do not cooperate, and most of the time, quite sometimes you just cannot see fundus at all. Okay, and this is what non-dilating pupil, you stand, get the camera, the fundus photography done here, and almost entire fundus I can see. So we have significantly reduced examination under anesthesia now. So what my protocol now I follow here is, if patient is not cooperative, I send them to Ophthalmology. If sometimes most of the time they cooperate, because it's just the most important thing is quick acquisition of images, hardly take few seconds. They do not have to focus, just multiple pictures they take. So, and if you see the fundus clearly, these babies, they do not need examination under anesthesia. And of course I tell them that if it doesn't cooperate for a picture, we will probably do under anesthesia, but risk of anesthesia, I am sure pediatric neurology anesthesia department understand. With all these premature babies, weight somewhere around 1.5 to 2 kg or 3 kg, giving them anesthesia, huge amount of risk. Parents are tense. I have to take the consent that baby may die during anesthesia, and you feel bad about that. But life has become much easier with this, and this is what today's imaging stands here. So coming to fundus fluorescent angiography, that's another invention, rather changed the practice in ophthalmology. And that 30 or 35, 55 degrees field we routinely used to see, and this is probably only way. What you see that image there, video small clip, dynamic evaluation of the retina and choroidal circulation, both and fluorescein or ICG angiography what we do here. So, and it's a first widely, it's a routine practice now, and of course we will come to that, and this is still last few years, angiography and few cases still integral part of our particularly posterior segment practice. And basically when you study all vascular disorders of the retina, this angiography becomes separable, and fairly safe technique, gives a good image. And this is just to show a few pictures here. Angiography, as the dye goes through the system, a periodic interval, we just take a serial photograph, and what you see, what your fundus doesn't see probably, as you can most of the time, sometimes difficult to make it. This is a Claris photo, you can't see much of vision, but you go on subsequently serial photograph, and what you see is pick up those lesions. Probably sometimes you can pick up on a indirect ophthalmoscopy or 90 or 70 diopter lens, but subtle lesions probably angiography gives again best picture. And most important, to pick up ischemic areas which probably clinically you may not be able to pick out, and because you decide treatment ischemia is there and where is neovascularization. And these are again what you see is in what you need. Angiography is useful in retinal vascular occlusions, diabetic retinopathy. This is AMD or PCV, polypoidal choroidal vasculopathy. And this is last one photograph, because you can't make out anything here in this picture. And this is choroidal circulation compared to other here. Choroidal vessels are seen extremely well here, which otherwise you just can't see at all. And you have what we call as hot spots here in a macular area, which extremely difficult to pick. Plan treatment accordingly with this. Coming to another important investigation or imaging modality, I would say optical coherence, and it has changed the practice again what we do, and also is brought in another minimizing the use of fluorescent angiography, because it's still invasive and give people allergy as well. So this is just timeline when you took out get out of the concept of seeing inside the and first prototype was devised in 91, and image in vivo was taken in 93, and commercial OCT was available in 1996, and then subsequent to time domain, spectral domain, and what you're going to Swiftsor domain, OCT. So basically what OCT is image is created by analyzing the time delay magnitude changes of the low coherence light, and as it is backscattered by ocular tissue. It is synonymous to particularly what we do is ultrasonography, because backscattering of the ultrasound wave, and similarly it happens in a light waves reflected. And just these two pictures what I am showing here is typically, this is OCT image, and down is what you have is a histopathological section of the retina, and that is exactly what OCT does, gives us histopathological section, each layer by layer. With current OCTs are giving you all 10 layers of the retina you can make out, and even few more than that. So this is old time domain. You can see differentiation is not that good, but some still you can see. Goes on spectral domain OCT, another technology where its speed is more, wavelength is different, and it gives not only 10 layers, but now part of vitreous you can see, part of the choroid also you can see here, what you are seeing here, and then so-called enhanced depth spectral domain, then again gives a much better image of choroid now, and partly, and then this what you have called as sweeps of technology. It has given now applies like a vitreous also you can image right from the vitreous up to the entire choroid and all 10 layers of the retina, and this become now again an essential part in all our retina practitioners armamentarium. So, and this newer thing coming up is ultra wide field imaging SSOCT. This is combination of your wide field fundus photography, and along with you have OCT added on, and even extreme retinal periphery you can pick up, and that's why again minimizing the use of fluorescein angiography now. Of course, there are certain specific indications are there for angiography. These specifications are for mainly for OCT, but you can just overlap and you can have a combination of both what you want to choose. And the added now is so-called OCT angiography. So basically, you can pick up flow signals in a retinal blood vessels. So basically, movement of RBCs are captured, and like almost more than 1 lakh scan in a second, and displacement of RBCs is picked up, and that is what gives is a map. What you see this what we call as OCT angiography, and because dye, when you inject dye-based angiography, dye does leak, and that's why we pick up new vessels. Choroidal vessels, they leak, and when dye comes out, things become someplace smuggy. So choroidal circulation, that's why it's difficult to examine or study when you are doing fluorescein as against ICG, because it doesn't leak that much. But then coming to OCT angiography now, there is no leakage of the dye, so that is very limited obstruction to your choroidal vascular feature. And also added advantage here is you can choose at what level, at what retina, what section you want. So we after OCT only we come to know there are 3, 4 or 5 different layers of vasculature, superficial layer, deep layer, and then go a choroidal layer. And what you are seeing is abnormal area. Routine OCT probably would have shown here something, but when you have a OCT angiography, this picks up, and it has changed our management, again help us to decision making when you are treating these patients. So this is just one patient. What you see here is a top image showing SDOCT, area of pigment epithelial detachment, and few high reflective spots are there. But in OCT angiography, pick up this neovascular spot. This is typically AMD having a subretinal blood clot here and new vessel centrally. And after treatment, you see these new vessels are regress here. Fluid which was collected on the retina, which was here, is already regressed now. So this basically, so diagnosis, planning treatment, and subsequent follow-up and manage subsequent decision. All those things, this become an integral part of our treatment plan. And then, because of this, another question now with now fluorescein angiography, where you see beautiful diabetic patient pictures of the diabetic patient showing entire, and this is again with a sweeps or technology. You can take a longer scan, 12 millimeter, 15 millimeter, up to 16 millimeter scan we can take, and we montage this. This is a montage picture of OCT angiography, and almost as good as if you see you are doing a fundus fluorescent angiography in these patients. And this is subsequent added now this technology along with miniaturization. This is a typical example of this. So now this sweeps out, that is a new OCT machines. We have miniaturized, and they are integrated with an operating microscope, and during surgery we have thinner layer, less than 1 millimeter thickness entire retina, though we use lot of magnification, but some few membranes, thin membranes sticking on the retina, and sometimes it's difficult to make out, particularly if you left anything behind during surgery. So intraoperative OCT, when you do here, these are the areas And of course, it was video I frozen here for the sake presentation, but you can dynamically, real time you see while operating, you can assess them, go back and pick them up. So that probably your dissection will be much more complete. And also added advantage now we are more and more we are going to gene therapy and subretinal injections of particularly gene therapy when you talk about. Now you need to go very precise location. It has to go in a subretinal layer or outer layer. So you can see your needle exactly what location your needle is while injecting. And that is probably will have much more relevance when you start gene therapy as a routine. And also is integrated what we called as 3D heads of visual display. I will come to that a little bit later. So newer OCT techniques, lot of things are coming. So and most important is combination of virtual reality along with OCT machines. So multi-user platforms are coming to management part of retinal detachment is separation of neurosensory retina to retinal pigment epithelium, and it's a commonest indication for all retina surgeons do. So when you look at the evolution of retinal surgery or management, there are three major steps what we get to know. So basically, first and most important obviously was ability to visualize the retina, and that's what happened. Indirect ophthalmoscope help us to do that. And then comes, because retina is detached, and we need to approximate this retina back to the RP choroid. And then we have a technology which in scleral buckling, pneumatic retinopexy, or vitreous surgery. To make it simple, scleral buckle, put RP choroid towards the which is detached. Vitrectomy you do, we put tamponading gadget inside and push the retina back towards the RP and choroid. So basically what you look at it, approximating this layer back to each other. And break is the cause for detachment. We need to seal this break, and then we have laser photocoagulation, diathermy or cryotherapy, both at this to induce iatrogenic inflammation. So coming to treatment options are scleral buckling, vitreous surgery, and combination of the technique. That's the three common thing. And in between there are small pneumatic retinopexy, link out balloon, which is a temporary one. Suprachoroidal buckle, we are trying to put some viscoelastic injection in the choroidal space to create a bud that will give a temporary buckle and it will get absorbed over a period of time. And this detachment coming, looking at the history, basically divided into three eras. Pre-Gonin era, that is the time when indirect ophthalmoscope was invented, but they just knew they could see, but they did not know what to do. Till Gonin explained and proved that retinal breaks are the cause of detachment and not construction deterioration. I was talking to Dr. Ashish, I said, I realized interesting fact. Initially I diagnosed detachment long back. They knew there is a retinal break, but lot of renowned researchers that time, they thought break is secondary to detachment. And it's a problem with the choroidal circulation, which accumulating fluid behind the retina, it drains out through the break in a vitreous cavity and probably through anterior segment. So initially inventors, what they did, they devise the technology to create additional break. It's like a draining path or something. So create more breaks in the retina. So assuming that subretinal fluid will get drained out and then retina settle down. And then in fact it will be other way around. And Gonin had a huge and most difficult time to convince them it's other way now, not the thing. Break is responsible for detachment, not the retina responsible for break. And it took really, he has to fight his way out. A lot of criticism till he himself did that whole thing. And what he basically red hot cautery used to create iatrogenic inflammation around the retina, and what basically he used to do is make the patient put in a post dependent position where the break is, put in absolute bed rest, fluid somehow get absorbed to some extent, and we also, all retina surgeons, all of us know sometimes giving absolute bed because of turbulence is reduced, vitreous itself sometimes acts as a tamponade, retina settles down, and then you open up sclera, conjunctiva sclera and use the cautery, puncture with a Van-Graff's knife, do cautery there, and once the seal create iatrogenic inflammation, his success rate of detachment management is almost jump from 0 to 53. The single-handedly he proved that management of retinal detachment, and that's why that window comes between Gonin's era. And then people, they did not have any choice but to accept Van Graffen group and all those things. They started accepting, and then of course it's like a Columbus and egg theory. Once people get to know, and when now you know the pathology, we know the etiology, then things are rapidly changes, slowly things, and because we know pathophysiology, rather I would put it that way. So then what to do? Option to reduce the traction, to push the sclera in scleral resection, try buckling the sclera. People have tried band around, some sponges. Basically, once you know that, then things are rapidly started changing, and most important landmark, again, Linkoff came out with using a sponge and cryotherapy instead of having a diathermy. So coming again subsequently, Skippen again caused because he has brought the buckle in. So he got a buckle and cryotherapy that changed the management to some extent. And Robert McKimmer, he brought concept of vitrectomy. First report he presented in 1970, that is vitrectomy for vitreous hemorrhage, and he proved that I can survive without having a vitreous behind it. Now what he has here is basically first prototype vitreous cutter he has created, what they call as whisk, vitreous, infusion, suction and cutter. Basically it's a full function probe, the word used. It was 16 gauge, 1.7 millimeter with a single opening, everything was going inside, and that's why he manages vitrectomy. Now there was a problem here because one single port, large probe, you can't see properly, no versatility, stability of the globe, and those issues always were there. So we'll come again now, and then people that come with, I think few slides I'm missing in between. We'll come to that little bit later. So coming to scleral buckling, just a brief about it. What exactly it does is cause inward indentation of the sclera and choroid to basically approximate the break along with sensory retina. And also once you push inside, the break, which is generally due to vitreous traction, naturally everything you are pulling in, so relieve that traction on the break patterns down, and this is the most accepted. What you do is put the sutures on the sclera and put the silicone sponge or silicone band over the sclera, and we tighten it so that it pushes the sclera inside and it holds it there. Now this is another great invention was spatula needle. I do not have to tell surgeons here how important spatula needle for us, and that is what is brought another concept, and that's what Linkoff's concept using a spatula needle in the scleral buckling surgery help us out. So this is a picture showing what you have a retinal break here, large break, and you have a detachment, and this is what you are seeing a buckle effect here, retina settled down, and you have break is like a flatten on the retina, and retina got cut. So coming back to this full function probe, different people modified it subsequently over a period of time, and then comes something called a split function probe where infusion was separate, and then you have cutting, and you have to aspiration. And aspiration is separate, and you have another illumination is separate. So what it become now, after that over period of 30-40 years down the line, that become a standard technique for vitreous surgery, 3-port pars plana vitrectomy, entering in a vitreous cavity through the pars plana. Light pipe goes through one, your gutter and aspiration goes through one port and infusion line through. And then that is invention of almost, it's become 16 gauge, become 20 gauge. Until last, I would say 15 years, all of us were doing, and we are this one. Now as far as Indian part of concern, there was no question of VR surgery prior to 80s. And these are 3 pioneers, Dr. Badrinath, Dr. Nam Parimaliswamy from Arvind Madurai, both of them trained by Dr. Charles Skippen. They brought American concept and Charles Skippen's concept of retinal surgery in India. And Dr. Nagpal, who is in Ahmedabad, he brought European concept of practicing vitreous surgery in India. And first vitrectomy in India was done by Dr. Nam Parimaliswamy. This was initially single probe. This is the machine, and I'm thankful Dr. Kim, recently I was in Madurai to grab this photograph from him. So this machine basically devised by Payman. That time we did not have machines anywhere, and he used to go wherever go, he'll take that machine. If you want to operate, I'll bring my machine. The concept is coming back again. People go with a laser machine and everything now. So But this machine he brought in, and first surgery, vitreous vitrectomy was done in Madurai, the G.R. Rajaji Hospital there. And then subsequently, actually, Dr. Nam Parimal Swami, Dr. Badrinath, they sat with local our technician, and then they started devising. So, and this is standard 20 gauge we are doing. Coming back now, things are again becoming smaller and smaller. So minimally invasive or micro-invasive vitreous surgery we talk about. So we have 20 gauge become 23, 23 become 25, and we are using 27 gauge instrument. So, and all the possible instruments what we need are available in 27 gauge also. And also most important thing is when you make a sclerotomy, we use a Tokar cannula system with that MIVS, and they are wall. So fluid leakage, particularly intraocular pressure during surgery, is maintained extremely well. Fluctuations are much less. So globe health-wise is far better now at this. And what does MIVS do? This is a photograph post-surgery 1 week. I had difficulty checking in OPD which eye I operate. Which otherwise 20 gauge when we used to do like lot of inflammation, subconjunctival hemorrhages, and patient, and then because of stitches are there, patient will be comfortable for next 3-4 weeks. Though we use absorbable stitcher, the knot will always keep on irritating. But this is what makes 25 or 27 gauge now. Things are totally different. Then all eye is obviously better condition, and cosmetic appearance also people are more concerned about as well. So that look into it. Coming to cutting rate value now. When we started vitrectomy even late, we were using 400 cuts per minute. That becomes 600, and it went on long time till 800 and 1000. Probably Paritosh would know, and Dr. Vatsal Parikh also would know what we used to do. And now things have changed rapidly, and now we are using hyper-width tube, something like a 20,000 cut rate. Now what does really difference with this high cut rate? Does it really make difference when you're operating? It just sounds number. It's not actually. When you see those two animation there, you see compared to previously what used to be there, and because dynamics and fluidics is so good now that there's hardly any tug on the vitreous, no pulling of the retina. So just let me play once again. Look at this first picture and this picture. This flap is the way it is moving here, there's hardly movement here. So surgery become technically extremely simple now, easier, safer rather I would put say, very, very safe surgery, so that you can almost shave the retina now without any hesitancy. What previously used to be worried about, a lot of iatrogenic brain, because suddenly retina jump into ports were big. And also another advantage here is now the port is so close to the tip. That's one more reason we can go very close to the retina. And this is another change in this tip has become now bevel. So when you inside the eye, it's oblique. So actually this tip is far away, but with this, now you see what happened here is because you are literally shaving the membranes. Again, it's gone. Okay. Just it's like a lawnmower, shaving the membranes on over the retina. So it significantly eliminated the use of scissors nowadays. Previously, more frequently we used to use. So cutter does most of the job. And then another animation, just I wanted to show here, just comparison, both are 25 gauge. What I am using here is a video just to show comparing exactly same step I am doing here. Here I am using scissor to cut this attachment, tiny attachment, and same thing I could achieve now because of this 25 gauge instrument. Now high speed you need, but not necessary you need high speed everywhere, and I should use because it's available. This is when I am using scissor, I cut down the, reduce the cut like a scissor. I am using automatic scissor. Cut rate is somewhere around 500 or 600 cuts here. But it exactly just to matching this to show that cutter does exactly same work what previously used to do scissors. So coming to visualization, and that again changes because when you have miniature instruments, and illumination is become important because your illumination also cuts down because your probes are small, and all endoscopic I am sure they are aware of now. So we used to use older lens system. They give a very, 20 degree or 30 degree view of the fundus. Yeah, they used to stable, but view was always the issue, and somebody has to hold these lenses, and lens is moving, and you are totally assistant dependent. And this is what was view previously, what you operate these eyes here. So central area, we did have some different modifications of, and these are different type of lenses we try to use. But still, with the prism lenses, view it become easier, be better, but not really. What you see subsequently is difficulty in what peripheral vitreous and peripheral retina is always used to be difficulty. And then obviously peripheral quality always used to people, and they have a lot of limitations. And then come wide angle visualization system, better illumination. So there are different again options available here. But what, just look at it, this gives a panoramic view. This is small pupil now here, panoramic view. But with through that, even and this is what the view when you put your lens in patch, so almost beyond equator periphery you can see the same. So you are not worried about previously limitation what we used to have pupil. And then of course you need a brighter illumination, gives an excellent source. This is another patient, this ROP baby I was operating. This is the view which that regular Landers lens we used to gain, and this is the same eye when you see comparing, we are going far beyond. So you see more, obviously you can do more and much better job. And most important when you are dealing in a blind dark cavity, once you see all these things, your orientation is in far better, and you are much more confident in handling these eyes. So, and this is the latest one in a thing now, 3D heads-up display for VR surgery. You just look at this screen here, not through the microscope anymore. These are 3D displays, and what is typical view of the operation theater is surgeon is looking at the screen here. The advantage or disadvantage all VR surgeon used to have is only surgeon and assistant is seeing through what is going on inside. Nobody knows what is going on. But now everything comes on a display, and so other people naturally were not much interested. But when everything is displayed on here, surgeon also looking at it, and it's a zoom now, like a very large picture, exceptionally good depth perception, and that's why surgeries have become much better. But there are issues here also as well, because it's, you are looking at optical image and not really tissue directly. So there is aberrations will be there, color changes or something, bleeding, it is more LERA practical issues are there. But this is another issue, but most important is exceptionally good teaching tool, because everybody can watch what is happening, and that generates interest also, like observers they are around. And this is again another display what is coming up. Typically Israeli, they are coming, they know for this technology. That's all, put on your head on, and it is like that jet fighters pilots, they have a visor in front of them, and then they all coordinates, they come on this, and they all see here. Do not have to, you can move it wherever you want and still operating, and you have everything is in front of you. And this is what is newer thing coming up. So, and now with that added on what I was talking about, OCT angiography, so that integrated intraoperative OCT, this is what you see. While operating, I know this is a hole here, and there are few membranes where there. So you go back, peel those membranes, flatten this macular rod before you close up. You ensure that everything clean job is done. Just this is basic steps of vitrectomy. I think just I'll skip these steps. What I wanted here is basically giant tear, what we define as retinal tear. What you see is large tear along. It's one of the most difficult case once upon used to difficulty in managing. Now the problem here is because retina is mobile, you try to settle it down, whatever you do, the flap slips down. Retina doesn't settle because globe is having a curvature, it's a ball-like thing, and peripheral retina is gone. When you do anything, it just settles down. And this used to be one of the most difficult surgery, and those days there was no other way to handle. It used to take almost 6 hours, 7 hours surgery, and the surgery was like this. You tie the patient here on your table, intubate, and then turn the patient all the way around. Okay, all around, and then surgeon goes on the stretcher under the patient. Okay. So whole preparation used to take almost a year. He is Dr. Lingam Gopal here, one of my teachers, doing surgery, and our anesthetist, they used to be hell of a day, and now this is he is underneath. That's the way surgery used to be, and that become now one of the simplest surgery with the invention, or not invention, use of perfluorocarbon liquid. Now perfluorocarbon, we all know, is an excellent oxygen carrying capacity, and is used as a blood substitute where you have a shortage of blood transfusion, particularly trauma cases, particularly they used to use in war injuries. So what happened here is now detached retina, you just, and it is heavier than water, it settles down, start filling the eye from posterior to anteriorly, and as the process goes, it keep on ironing out the retina, things become simpler. So surgery has become just take maybe 45 minutes to 1 hour now, and it's like any another routine surgery people talk. And this is one of the very important change what we had in management. Coming to anti-VEGF, we were talking about, this is another newer invention for this era what you have ophthalmology, and basically wherever you have vascular endothelial growth factor, these are the disorders: ROP, diabetic retinopathy, RVO, and ARMD mainly, and that's changed the management, the way we deal with. And excess VEGF basically is due to secondary response to ischemic retina and increased permeability of existing blood vessels, so causes edema, and new vessels causes bleeding in other tissues. So these are conditions. So what anti-VEGF does is basically blocks the activity of vision. So these are the, again, timeline. First it is like somebody described as a factor X, something they were not sure, but what first time it got approval for cancer treatment, bevacizumab, what we use, or Avastin we use for a cancer treatment, and that is 2004, and that changed again management of the entire medicine side. And of course immediately got approval for wet age-related macular degeneration. That was macugen we used to call about, not Avastin, and then Avastin we started using, and curve goes on very rapidly, leading to now what is called as faricimab, then in between brolucizumab, before that aflibercept and ranibizumab, and now what we are having a biosimilar in pipeline. And these are common disorders. We are, I think, it's very change the management routinely. Why I wanted to change, basically we'll come back a little bit later on. These are vascular disorders, and we used to use only treatment available for this managements were laser treatment, because what we learn, because I just basically what importance of this ROP trial, what I'm looking at it is ROP and oxygen supplemental. Again, nobody thought about it, because premature baby when they born, survival oxygen needs to be there, and everybody thought oxygen is integral part, and uncontrolled oxygen was going on. And then Dr. Campbell in Australia, she realized there is some association, because it's a where we are giving uncontrolled oxygen, somehow those NICUs having a higher incidence of, they used to call as retinal fibrillation, is what we call is as stage 5 ROP, last stage, white pupillary reflex. And where they are not giving adequate oxygen, probably their incidence is low. There's something is there, but she was not sure. But when the PATS, who was a resident that time, and Ashton basically is a pathologist, they started working on it, and the most important part here was that was the first animal model ever created in the history of medicine. So they have, and it was the first ever national cooperative, what we call as multi-center randomized trial, that brought in the concept of multi-center trial. And that is holds good. Now we all do, now we familiar, but that was the first thing, and that changed the treatment, and with that multi-center trial, they proved oxygen is responsible. And then Taylor made a neonatology practice change. After that, incubators came. You have blenders have come into the picture, and regular monitoring of oxygen saturations is happening, and that's the way ROP practice changed, and we have significantly reduced the incidence of ROP. So again, but that also brought two more important things. Wherever ischemia is there, and that is a culprit we need to take care of, and we need laser is important for that. So whether it's diabetic, whether vascular occlusion, where is ROP, do laser. And then we come to know this anti-VEGF comes into play. And when where VEGF comes into play, so we have now anti-VEGF. So partly now is a combination of laser and anti-VEGF, and that's where whole scenario has changed now. I'm just not going detail this surgery, ROP surgery. This is what basically. Just last part, this one coming to management of, again, age-related macular degeneration. We did not know what it is, basically mechanism, but what we know it is because of ischemia, we started doing laser. Now, extrafoveal, juxtafoveal neovascular membranes are okay, but when it's subfoveal membrane, when you do laser, basically laser is you're burning the retina directly there. So there is a sudden drop in the vision. But what we used to justify, telling the patient that if there is a sudden drop, but probably you sustain that vision rest of the time, and this is one of my patients. She is maintaining the 660 vision. I did laser for her 22 years back. Okay, she comes for regular drop, but she is holding that 660 till now. She came like recently for checkup. Now this is another patient I saw yesterday, basically. Laser was done. This is the thing. We literally burned out the fovea here. Okay, but he is still 6.7.5 in this eye. Other eye he had a atrophy, so all those things. But now with anti-VEGF, we do not do that. This is the same patient. We do not do any more that part. We don't do macular. Extrafoveal, still we use a laser, but foveal, subfoveal started using anti-VEGFs, and this is one of the picture as you see here. you give injection, and this is what sub changes you see, this settle down. But yes, the downside is this ranibizumab or other anti-VEGFs anyway, we need to keep on repeating injections almost every 1 month and 2 months or 3 months. And what we are looking at it now, basically future, basically we need a long-acting drugs or sustained release delivery system, probably number of injection we can reduce, because otherwise the direct injury. I am not going to detail in a diabetes, I think we are going ahead full. But again, diabetic management, just to say about things have changed, diabetic management and both ROP, both the things. One is because of this ultra wide field imaging, and we know these are the preventable diseases. So now focus is more on a prevention rather than treatment. And the ROP trial, what I told is, that also brought that, there is another learning from that study was, there is no point focusing on treatment because you already miss the bus. So that also important guideline, important thing we learned from that trial is, bring in a prevention, early screening, and you can avoid these disorders. The last part is basically the word about gene therapy. The projects are for human genome going on, actually started at 20 years back, and it's have now much better understanding about gene therapy we have. And these are, as of now, 3 or 4 disorders we have targeted all over the world: Stargardt disease, RP, and we are working on diabetes retinopathy and ROP as well. So Luxturna is the first approved drug for as a gene therapy for retinitis pigmentosa basically. But only problem with all these gene therapy here is they are gene specific. And we all know most of the diseases are having a multiple genes are involvement. So as a routine now, again we do all this genetic patient, we get a gene mapping done for every case. There is no treatment for every gene except this one now, but there is a time will come. So that's a major limitation with gene therapy is it has to be specifically to that targeted gene, so otherwise it doesn't work. And obviously it's a huge cost it comes with it. So most of the people, they do not afford that. The last one is artificial intelligence. Nothing can end now without artificial intelligence. So large data is fed up, and it's something like a morphological fingerprint, and it gives us lot of analysis. And Retina, obviously ophthalmology is not exception to that. We are having AI algorithms. We have a lot of contribution now with the Google projects and Microsoft projects we are coming into, and this is what Sundar Pichai says.
Mission of our team's efforts to bring the benefits of AI to everyone. And we want this to work globally, so we are opening AI centers around the world. AI is going to impact many, many fields. I want to give you a couple of examples today. Healthcare is one of the most important fields that AI is going to transform. Last year, we announced to work on retinopathy, which is a leading cause of blindness, and we use deep learning to help doctors diagnose it earlier. And we've been running field trials since then at Aravind and Sankara hospitals in India. The field trials are going really well. We are bringing expert diagnosis to places where trained doctors are scarce. Using the same retinal scan, things humans might know to look for. Our AI systems offer more insights. The same eye scan turns out both information with which we can predict the 5-year risk of you having an adverse cardiovascular event, heart attack or strokes. So to me, the interesting thing is that more than what doctors could find in these eye scans, machine learning systems offer newer insights. This could be the basis for a new non-invasive way to detect cardiovascular risk. And we just published research, and we are going to be working to bring this to field trials with our partners.
So this is what AI about now, and of course now Alzheimer also we know AI is picking up only looking at the fundus scan. So just to conclude, future is integration of fundus, photography, angiography, OCT, basically multi modal image modalities, and quantitative autofluorescence other coming into as far as imaging concerned. But challenges are there. Pharmacological and technical innovations has revolutionized management of retinal diseases. It helps to achieve proper diagnosis, plan appropriate management, and thereby helping to improve the efficacy and reduce side effects. But it comes with a high cost, limited accessibility, and will have difficulty in widespread adoption. I just thank my colleagues. They helped me to get this presentation ready. Thank you once again. Thank you very much for having me here. It's a great honor to be here.
Thank you, sir, for that wonderful presentation. Even though many of us in the audience are not ophthalmologists, we were absolutely captivated. The leaps and bounds from doing surgery on a stretcher to AI in healthcare. It's truly very exciting. I would also like to welcome amongst us Dr. Milind Sathe, who is head of Vitreo Hospital. Thank you for being with us, sir. I request Dean Sir Dr. Mohan Joshi to honor Dr. Bhende with shawl and shreefar. I request Dr. Prabhakar, our head of surgery, to present Sir with a memento on our behalf. I invite Dr. Sandhya Iyer, Professor Surgery, to present a painting to Sir, which has been specially crafted for him. It is by Mrs. Kala Vaidya, the renowned artist, and it depicts the river Varanasi on this auspicious occasion of Mahakumbh. Dr. Chhaya Shinde, our head of ophthalmology, will present Sir with the citation for the S.R. Talwalkar Oration. Thank you, sir, for being with us today and for your valuable time. Who is ex-head of urology and has been a pioneer in the field of cadaveric renal transplant. I invite Madam and Sir Dr. Dilip Trivedi to the dais, please. Dr. Prabhakar, who will introduce Madam.
Dr. Vasala Dilip Trivedi, MBBS and MS General Surgery, later on MCH in Urology. He was an ex-professor and head of Department of Urology at the Governor. He was the founder secretary of the ZTCC in Mumbai. He is the president of National Disease Donor Network, a national body for promoting organ transplantation. She has also received the Mayor's Award, Top 20 Women Achievers of India, Chikitsa Ratna Award, was invited to WHO Geneva for developing diseased donor transplantation in developing countries. She was invited to Rajya Sabha for discussion on amendments in the Transplantation Act. She was invited to Nepal for initiating the diseased donor program in Nepal. Dr. Dilip Trivedi is an ex-professor and HOD of surgery at Nair Hospital. He was a pioneer in hepatobiliary surgery and total hypertension surgery. He is currently working at HN Hospital, Mumbai.
I request Dr. Meena Kumar, our ex-head of surgery, to felicitate Madam on this momentous occasion. Meena Kumar Madam has been a close friend and colleague of Trivedi Madam. And now inspiring to see your achievements.
To see so many of my colleagues in this hospital, let me tell you, this was not my alone destination or achievement. Entire LTMG was like a family who has stood with me. I think many of the old faces I can see, the amount of night light that we have burnt for doing cadaver transplant or setting in this general hospital was phenomenal. I thank Malde, my anesthesia department rather, they were extremely with me, including biochemistry, microbiology, physiology, psychiatry department, medicine department, intensive care, all were together to reach to this distinction. I am proud that Sion Hospital is a general hospital, but first hospital in entire country to start the disease donor kidney transplantation. It is recorded in the center also that Sion Hospital was the first, for which I am very proud of it. Thank you so much, Dr. Mohan Joshi. Can I say he was my first resident, and that's why we have that one. He's dean now, but he was my first resident. In 1985, 86, I don't remember. He was my general surgery. Thank you.
It's been such an honor to be a part of this wonderful oration. On behalf of the Department of General Surgery and SRS, I would like to extend my heartfelt gratitude to our esteemed guests, Dr. Pramod Bhende sir, Director of Vitreo-Retinal Surgery, Sankara Nethralaya, our Dean Mohan Joshi sir, Prabhakar sir, our Head of Department, Chhaya Shinde Madam, Head of Department Ophthalmology, our Staff Research Society, Dr. Shripad Taklikar, Rupal Padiyar, Rahul Mayekar sir, Dr. Hina Merchant, our chairpersons, and SK Healthcare, our sponsor. And thank you, Physiology HOD sir, Dr. Amit Fadia, for providing us this venue. And all our staff members and residents and all the dignitaries who've come here. Finally, I would like to thank all of you present here for making the time to be with us today and helping in making this oration a grand success. Thank you.
I request everybody to join us for lunch in the auditorium foyer, and all the senior faculty, please join us in Physiology Library for lunch.